Where's the yeah, that's what they did.
Okay.
And she was.
All right, good evening, everyone. So first of all, I want to say thank you to our exhibitors. Thank you to everyone who participated in the raffle challenge. So I guess, will that be announced at the end then? Okay, very exciting. Thanks to the exhibitors for helping to sponsor tonight's dinner and talk. So this is the agenda. Our speaker tonight will be Dr. Kyle Perry. Dr. Perry is a surgical and cytopathologist at the University of Michigan. He is the section head and fellowship director for bone and soft tissue pathology. Looking at his CV, Dr. Perry completed, I think, 3 fellowships, one in surgical pathology, one in cytopathology, and because he's a glutton for punishment, 3rd fellowship in bone and soft tissue pathology at the Mayo Clinic in Rochester, Minnesota. For this, he completed his residency in anatomic and clinical pathology at UNMC here in Omaha. He's board certified in both anatomic and clinical pathology as well as cytopathology. His academic interests include translational research, pathology education, QA, and the application of digital pathology and data science to improve patient care. So with that, I will turn the meeting over to Dr. Perry. Thanks for joining us, Dr. Perry.
Yeah, thanks, Ben. Can you guys hear me okay?
Yeah.
Okay, excellent. Okay. Yeah, thanks for inviting me to speak. I have fond memories of Nebraska Association of Pathology. I don't have any disclosures relevant to this presentation, but I remember as a resident always going to Nebraska Association, and afterwards we'd go to the Venison, which I understand is no longer in Omaha or no longer an active restaurant in Omaha, but again, fond memories. What I wanted to talk about today, I thought would be helpful. I mean, to be honest, I think sometimes as we've gotten more subspecialized, like a lot of times we'll go to these lectures and, sometimes I've been in lectures where I'm just thinking like, what is this person talking about? Or, I don't know, there's a tendency, I think, to get real compartmentalized. And I try to like pick something that I think would be useful to a broad, a diverse group of surgical or anatomic pathologists. And I think inflammatory soft tissue tumors are of particular interest. And the reason why is because I think soft tissue tumors are particularly challenging when you're not even aware that it's a soft tissue tumors. And these inflammatory soft tissue tumors all share a common characteristic in that they're mesenchymal tumors that have prominent associated inflammation, making them particularly challenging because they could be mistaken for other processes such as infectious, inflammatory, hematolymphoid tumors or carcinoma. And, the lack of even, knowing that this is in that sort of soft tissue realm can further delay diagnosis and treatment. So with that in mind, I wanted to talk about just some common inflammatory soft tissue tumors in a case-based format, highlight some frequent challenges and pitfalls that I see, and briefly discuss some relevant immunohistochemistry and molecular studies, as well as talk about entities in the differential. And just full disclosure, this is not going to be comprehensive, but again, I think that by highlighting some specific cases, it can kind of at least bring in, a lot of the common concepts that are associated with inflammatory soft tissue tumors. So I think in terms of general approach to soft tissue tumors, a lot of times when I talk to, for the health officers in the audience, a lot of times my general approach, is there something going wrong?
Sorry, we can't see your slides if you don't mind trying to share them again.
Oh, okay. Yeah, that'd be a problem. Let me, sorry. I haven't really shown, it's all been a bunch of boring text so far, so you haven't missed anything.
There you go.
Good.
Perfect, thank you.
Sounds good. So in terms of soft tissue tumors, a lot of times we talk about, you assess the microscopic features, formulate a differential diagnosis, order immunostains, and if necessary, molecular studies. One thing that Tim Greiner, when I was a resident, that he kind of taught me when I was on the heme rotation with him is that he liked to use the clinical history as almost like another ancillary study. And so what he would do whenever he was signing out heme is that he would often look at the microscopic features and then use the clinical history as almost like a second ancillary type study. And I find that really, really helpful because to be honest, like the clinical history, I think is very important. And I would argue is almost as important as the actual morphology in itself in terms of establishing the appropriate context to interpret all these other data points. And that's particularly true in inflammatory soft tissue tumors where the morphology might be limited or cloaked by these inflammatory cells. So in terms of relevant clinical questions, just in terms of examples, that would include things like, is there lymphadenopathy or constitutional symptoms? Because a lot of these inflammatory soft tissue tumors can cause constitutional symptoms through secretion of cytokines or some sort of other mechanism. And that would include things like angioimmunotide fibrocystic follicular-dendritic cell sarcoma, retroperitoneal fibrosis sometimes, inflammatory myofibroblastic tumor, and so forth. Another question is, where is it located? Because the location really, I think, primarily also defines the differential diagnosis that you want to start considering. So, for example, if the mass is abdominal in location, you would think about IMT, well-diff liposarcoma, retroperitoneal fibrosis, and sclerosing mesenteritis. Or alternatively, if it's more superficially located, you would consider things like angioimmunotide fibrocystic nodular fasciitis, mixed inflammatory fibroblastic sarcoma, and so forth. So just to go ahead and get started, this is my first case that I had, which is a 45-year-old with a retroperitoneal mass. And here, consistent with the title of the talk, it's very inflammatory. And you see these really abundant lymphocytes. Again, these sort of lymphocytes and plasma cells are scattered throughout in the background of fibrous tissue. And there might be rare atypical cells. Again, that's stretching it in terms of atypical. To be honest, I'd probably, in any other context, would probably blow over these cells pretty easily, but they have somewhat conspicuous nucleoli. So this is an example of a well-differentiated inflammatory liposarcoma, which again can be exceptionally challenging, particularly on a limited needle core biopsy. In terms of well-differentiated liposarcoma, this is, I think the most common malignant sarcoma, and it occurs in middle-aged to older adults, usually in the deep soft tissue, in the extremities, abdomen, retroperitoneal, mediastinum, or peritesticular soft tissue. And most of us, I think, are aware, are comfortable with sort of the conventional types of morphologies of a well-differentiated liposarcoma, that you have this adipocytic tissue, which is traversed by these fibrosepta. And then within the fibrosepta, you have these atypical cells with enlarged, irregular, and hyperchromatic nuclei. Of course, there's other morphologic variations in that you can have sclerosing well-diff liposarcoma, in which you have very limited adipocytes, and it's mostly just background fibrotic tissue. But again, you see these atypical cells, again, showing these atypical cells in the dense fibrosis. But the problem with inflammatory well-diff liposarcoma is that you're not even really sure what cells to look for, because you have this really robust, dense lymphoid tissue. And again, showing this chronic inflammatory background with these very rare atypical cells, maybe right here, you can have them. And to be honest, even the atypical cells don't look, they look a little bit different than the atypical cells you associate with usual well-diff liposarcoma, in that they can almost take on this Reed-Sternberg-like appearance. And in fact, I've, had my heme colleagues, a lot of times will initially work up a needle core biopsy of a chronic inflammatory well-diff liposarcoma for Hodgkin lymphoma, and then it'll eventually make its way to soft tissue after, it doesn't work out like that. So again, if you see these Reed-Sternberg-like cells, just be aware that they could take on those sort of features in a chronic inflammatory well-diff liposarcoma. Additionally, in addition to a background chronic inflammation, you can also have an acute inflammation as well, a background acute inflammation. And I've seen it's not uncommon to get a consult where the patient has been worked up or treated as if it's like an acute abscess because of these background acute inflammatory cells. But when you look closer on higher power, you'll see these rare atypical nuclei, again, having these irregular and hyperchromatic type features that are sort of hiding in the background. Now, to be, completely honest, it's extremely difficult to find those atypical cells in the inflammatory component. But ideally, if you're fortunate, there's usually areas where it's less inflammatory, and that's a better place to start looking for these atypical cells that are characteristic of well-diff or acute inflammatory well-diff liposarcoma. So again, in this less inflammatory background, you can see these characteristic atypical cells here. Of course, as we know, MDM2 can be enormously helpful if you have a limited biopsy in terms of helping confirm the diagnosis, particularly if it's in an area that's highly suspicious for well-diff liposarcoma. This includes MDM2 immunohistochemistry and or MDM2 FISH. So this is an example of acute inflammatory well-diff liposarcoma, and then here's the MDM2 immunohistochemistry, which shows nice staining. Now that being said, in full disclosure, and I'm sure many of you are aware, like the MDM2 immunostain can be variable in terms of how sensitive or specific it is. So you know, if you're really concerned about it, I typically recommend fluorescent in situ hybridization, or at least be aware of how the MDM2 stain is performing in your lab, because it can be quite variable. But I have had success in terms of in the inflammatory subtype of liposarcoma with immunostains highlighting the cells of interest. In terms of differential diagnosis, as I mentioned before, Hodgkin lymphoma can look very similar. CD30 and PAX5 would help distinguish that, because of course, the Reed-Sternberg cells would be positive 30 and PAX5. IgG4 type of entity can also exhibit similar features, and of course, infection, as I mentioned before, particularly if you're dealing with an acute inflammatory, well-differentiated liposarcoma. In terms of the prognosis, it depends a lot on the anatomic location. If it's retroperitoneal, then of course, those tumors behave in a more aggressive fashion. And of course, a subset of these tumors can dedifferentiate where they transform to a higher grade tumor. And now if they're in the extremity, the prognosis is much better. And oftentimes we'll use the term atypical lipomatous tumor to communicate to our surgical colleagues that that is a less aggressive tumor. So that's the first case. Second case, 15-year-old with a subcutaneous mass in the upper arm with lymphadenopathy. And so here you can see this as a, as I say, like this subcutaneous based lesion. It's relatively well circumscribed, and there's a focal lymphoid cuff here. And then on higher power examination, there's a little bit of a whirling type of architecture with these cells that are mostly vesicular in nature. They're a little bit irregular with some grooving. Maybe focal atypia is present. And again, showing the higher power examination of the lymphoid cuff that you see here. So this is a nice example of an angioimatoid fibrous histiocytoma. Excuse me. Oh, excuse me. So in terms of angioimatoid fibrous histiocytoma, in terms of the clinical history, they typically arise in children and young adults, and they generally arise in the superficial extremities. And to be honest, this is one of these things where if you have the whole lesion, it's not like an incredibly difficult diagnosis to make. But the problem is that a lot of times we get these on needle core biopsy, which can be extraordinarily difficult to make the diagnosis, just because you're not sure which component of the tumor you're going to get. And depending on what component of the tumor, it can have a lot of histologic mimics. The other problem with these tumors is that clinically they can present in a way that's very misleading for the pathologist, because a lot of times these things can secrete cytokines or inflammatory markers that can elicit a lymphadenopathy. So it's not uncommon for the surgeons or for the clinician or the oncologist to be concerned about some sort of hematolymphoid type process, like a lymphoma or something like that in a child. So it can be there's a lot of misdirection type cues that you could be getting when receiving this. Usually what I tell, when I talk about this, I usually, my rule is that if I have a patient, like a, patient that's 20 years or under, or a young adult, and they've got a subcutaneous lesion in the upper extremity, then I almost think angioimatoid fibrous histiocytoma until proven otherwise, or at least make it a rule that that's a primary entity that you really want to exclude. And again, like the biopsy is going to vary depending on the component that you get. in terms of the behavior, 15% of these recur. The diagnosis is important because rarely these things can metastasize. So being able to communicate to your surgical colleague that, this is angioimmunotid fibrous histocytoma can help make sure that it's appropriately excised or completely excised just to reduce the risk of recurrence and the rare incidence of metastasis. So in terms of the histologic features, like I said, at low power, the lymphoid cuff can be exceptionally helpful in making the diagnosis of angioimmunotid fibrous histocytoma, or at least bringing up that as a possibility. And in terms of the morphology, these things can have a fascicular or store form like architecture. They usually a whirling kind of pattern. Sometimes you'll see this perivascular whirling as well. And again, you see this store form like architecture here. There can be occasional atypical cells, which can sometimes mislead a pathologist into thinking that they're dealing with like a more aggressive tumor, such as like an intermediate or high-grade undifferentiated pleomorphic sarcoma. But you do allow for scattered atypical cells in an angioimmunotid fibrous histocytoma. Like sometimes you can also get these blood lakes in angioimmunotid fibrous histocytoma. And so if you're not careful and they just sampled that part of the tumor, then you might be misled into thinking you are dealing with some sort of vascular neoplasm or something like that. So just be aware that you can have these blood lakes, and sometimes the hemosiderin can crystallize and you can get this orange hematoidin, which again should be a clue of a potential diagnosis of angioimmunotid fibrous histocytoma. Like I said, the lymphoid cuff is particularly helpful in terms of thinking about angioimmunotid fibrous histocytoma. So if you're fortunate enough to get that lymphoid cuff in whatever tissue you receive, that can also be another helpful clue. One other interesting morphology with angioimmunotid fibrous histocytoma is that you can get these myxoid changes, and it can get to the point where these myxoid changes can kind of spread the tumor cells apart in a reticular architecture, almost analogous to like an extraskeletal myxoid chondrosarcoma. And for some reason, Abbas Nagami and colleagues had a nice paper about a year ago on this, in addition to, I think, an older paper by Fletcher, where they showed that these myxoid angioimmunotid fibrous histocytomas, for some reason, have more of a predilection for the acral locations. So just be aware that you can have a myxoid variant of angioimmunotid fibrous histocytoma as well. So in terms of the ancillary studies, there's really not a great slam dunk immunohistochemical stain right now. EMA, CD9, and Desmond can stain these tumors. ALK can also stain angioimmunotid fibrous histocytomas. In my experience, it's sort of been hit or miss on these. I think there's also now a CRIM, like about a couple months ago, there was a paper, I believe it was a CRIM stain as well. I can't remember if that's in situ hybridization or an immunostain, which is promising. But, as you all know, like you sort of have to give any immunostain about 2 to 3 years before you're really going to get a good feel for the sensitivity and specificity. So, while these stains are helpful, they're not, I wouldn't necessarily allow it to make or break a diagnosis. And really, if you really want to assess for it, then FISH to assess for fusions associated with angioimmunotid fibrous histocytoma, such as EWSR1, CREB1, ATF1, or FUS-ATF1 would really be the way to rule it in or out. And that's, again, the way in situations where you really want to know FISH or some other molecular type of study like NGS is the best way to do that. In terms of the differential diagnosis, really probably the main one's going to be aneurysmal fibrous histocytoma, which, I got to admit, like soft tissue pathologists are just horrible at naming stuff. It's almost like we try to make it as confusing as possible. But as bad as it sounds, like those are actually two separate entities that are distinct in terms of biologic behavior and prognosis. But aneurysmal fibrous histocytoma is basically a variant of fibrous histocytoma, whereas angioimmunotid fibrous histocytoma is its own thing. And in terms of these typically will arise more in the dermis and have like this cystic architecture. And if you go to like the periphery, they don't have the lymphoid cuff that you would associate with angioimmunotid fibrous histocytoma, but have that basically that collagen collagen trapping that should help you differentiate. And of course, if it's, again, if there's any question, you can always fish for EWSR and FUS just to exclude an angioimatoid fibrous histiocytoma if it's ambiguous. All right, case number 3, 30-year-old with a lung mass, and here we see this dense fibrous tissue with this lymphoplasmacytic type of background. In other areas, it's a little bit more loose, maybe even myxoid with these plump nuclei and maybe small inconspicuous nucleoli. And so this is a nice example of an inflammatory myofibroblastic tumor. And this is always I think it's, even though inflammatory myofibroblastic tumor has been around for quite a while, it's still a challenging diagnosis. They can affect a broad age range, primarily children and young adults, but again, you can see them in older patients as well. They're primarily found in the abdomen, mesentery, omentum, retroperitoneum, but they can also be in the head and neck, amongst other sites as well. As I mentioned, some patients can present with constitutional symptoms thought to be secondary to secretion of inflammatory cytokines. In terms of histologic features, I think one of the problems with IMTs is they can really vary in terms of their features. You can have background myxoid or hyalinized stroma, and you basically have these cytologically bland spindled or stellate cells. The amount of inflammation can vary. Here you can see lymphoplasmacytic inflammation. And a lot of times they'll sort of have this store form fibrotic like architecture. Here it's a little bit more fascicular in nature, and this more cellular example of inflammatory myofibroblastic tumor. And you can even still have areas that are hypocellular, in which you just have more dense sclerotic collagen, where you don't really have that store form or fascicular arrangement. So again, you can have a lot of different morphologies, even in the same tumor, that make it challenging, I think, particularly if you're getting it on a needle core biopsy. Here's an example where you have more myxoid stroma in an inflammatory myofibroblastic tumor. And in terms of the cells, they basically have these elongated myofibroblasts where you have like these very sort of tapered cytoplasmic ends. And the cells, they can be enlarged, and sometimes they can get scary and sort of mislead a pathologist into thinking they're dealing with a more aggressive tumor than they are. But the nuclear, they should be relatively focal in terms of the nuclear atypia. So here you can see some nucleoli. Sorry, just. So sorry about that. Sometimes, again, you can see sort of these ganglion-like cells with this focal nuclear atypia. In terms of the smooth muscle actin, it usually has a very characteristic sort of membranous tram track-like appearance that you see here, where it's not like, unlike smooth muscle, like in a leiomyoma or leiomyosarcoma, you don't have the dense cytoplasmic staining. You have sort of this tram track-like appearance that you see here. And that's a good indication that you're dealing with a myofibroblastic type tumor. Now, it might not necessarily be inflammatory myofibroblastic tumor, but it can help you know that you're dealing with a myofibroblastic-like proliferation. And of course, ALK, it's always a good day when the ALK is positive, because that essentially helps confirm the diagnosis in the appropriate setting. But the problem is that ALK is only going to be positive in about 50 to 70% of cases, because there's other mutations associated with IMT. The next most common would be ROS1 in 5 to 10% of cases, and then NTRK3, PDGFRB, RET, among other genes, can also be associated with IMTs. So you have to be careful not to as tempting as it might be, not to over rely or overstate your sensitivity just on a negative ALK stain. We typically use the D5F3 probe, which I believe, or the D5F3 clone, which I believe is the most sensitive for soft tissue IMTs. Other problems is the keratins can often be positive in these IMTs, which can sometimes mislead pathologists in thinking they're dealing with a sarcomatoid carcinoma, when in fact you're just seeing keratin staining that you can see in myofibroblastic type proliferations. In terms of differential diagnosis, IgG4 sclerosing disease, histiocytic spindle cell pseudotumor, amongst some other things like liposarcoma, Hodgkin's, just can be problematic. I think like these IgG4 processes, like such as retroperitoneal fibrosis or sort of these IgG4 type fibroinflammatory lesions, I think it can be I think people can really underestimate how much morphologic overlap you can see between those and an inflammatory myofibroblastic tumor. So, this is an example of retroperitoneal fibrosis. Again, sort of part of that IgG4 fibroinflammatory kind of family, where you have this store-formed fibrosis of dense collagen with lymphoplasmacytic background. But if you look, IMTs, they can also have areas of increased IgG4. And I think that's one of the pitfalls, is that sometimes I think pathologists overplay their hand when they see an increased IgG4. And to be honest, like, there's so many entities or so many processes that can have IgG4 other than, retroperitoneal fibrosis. So just because you see an increased IgG4, you still have to go through all the motions of thinking about all the other inflammatory type mesenchymal tumors before you jump on something like a retroperitoneal fibrosis. And so this is an example. For example, this is a case that we saw a couple years back, where you had this fibroinflammatory process, where you had these dense areas of fibrosis, you had these areas of increased IgG4, and I think like the patient probably for like a year kept getting diagnosed as like IgG4 type fibroinflammatory process, and like was not responsive on steroids or some other type of immunosuppressive agent, and it ended up actually being an IMT with a TFG ROS1 fusion. So again, it never hurts to think about IMT, particularly if you're going to start talking about making a diagnosis of an IgG4 process or retroperitoneal fibrosis or something along those lines. Hodgkin's lymphoma would also be in the differential diagnosis, so excluding like hematolymphoid process, like a low-grade B-cell lymphoma or Hodgkin lymphoma would be important. And also histiocytic proliferation, so making sure that it's not a histiocytic proliferation in terms of a myofibroblastic proliferation, that could also be in the differential. Appropriate identification is important, because these tumors can often recur in about a third of patients. Risk factors are larger tumor size, older age, abdominal pelvic location, and rarely they can metastasize. So ideally, you'd like to correctly identify it and resect it the first time around, if possible. In terms of case number 4, this is a 40-year-old with multiple intra-abdominal masses, and I believe in the abdominal cavity. And here you can see that we have this proliferation of basically these epithelioid-looking cells here, with these prominent nucleoli in the background of this myxohyalinized type stroma, and there's some background chronic inflammatory cells, maybe some neutrophils as well. So this is an example of epithelioid inflammatory myofibroblastic sarcoma. So we just got done talking about inflammatory myofibroblastic tumor, and this is an entity that was described a while back. I believe it's considered to be a, quote, variant of inflammatory myofibroblastic tumor, although to be honest, it's much more aggressive in nature. Hence, we use the term sarcoma when describing this. Common sites also include the mesentery omentum, and unfortunately, it affects children. It disproportionately affects children and young adults. So the histologic features, like the name implies, you basically have this, instead of these elongated spindle cells with this sort of tapered cytoplasm, you have these cells that are predominantly epithelioid or round in nature, and instead of like these small little inconspicuous nucleoli, you have these very prominent nucleoli that you can see here. And there's usually background like neutrophils, as well as this really dense eosinophilic cytoplasm, almost approaching like rhabdoid or at least amphiphilic in terms of in nature. Again, just showing these really large nucleoli here, almost like CMV-like. And of course, one of the characteristics that these are positive for ALK, and they have a characteristic perinuclear ALK staining, which is associated with this epithelioid inflammatory myofibroblastic sarcoma. Alternatively, a small subset can also be like a perinuclear dot-like staining pattern, but again, particularly for residents taking boards, this circumscribed perinuclear staining is what's going to be tested or most associated with epithelial inflammatory myofibroblastic sarcoma. In terms of the differential diagnosis, anaplastic large cell lymphoma can come up in the differential diagnosis, given that these can also be positive for ALK and exhibit some similar cytologic features. These should exhibit strong and uniform staining for CD30, with the key being strong and uniform. And they can be positive for other hematolymphoid markers. There's also CREB1 fusion associated epithelial mesenchymal neoplasm, which I'll just talk about a little bit in just a second. But so just to emphasize, so if you're not careful, you can overinterpret or misinterpret a CD30 on an epithelial inflammatory myofibroblastic sarcoma. So here you can see sort of this granular like staining pattern, but that really shouldn't be interpreted as positive. It should be, hematopathologists like to say, it should be like a magic marker where you're just like outlining it with a very, very strong, magic marker. And so the granular staining pattern shouldn't really be considered to be sufficient in itself in terms of excluding epithelial inflammatory myofibroblastic sarcoma. Just talk a little bit about a newer entity that's sort of coming up now. Is this CREB fusion associated epithelial mesenchymal neoplasm? And to be honest, it's kind of a messy area right now where there's probably like 8 different names for it, and it kind of still hasn't. I think the terminology is still in process. It shares the FET CREB type family fusions. So EDBSR ATF1, EDBSR CREB, EDBSR CREM. Similar to angioimmunotid fibrocystic or clear cell sarcoma of soft tissue. And the reason I wanted to talk about it is because it also can occur in the same abdominal cavity and be deep-seated involving visceral surfaces. Here you see an example of this CREB fusion associated epithelial mesenchymal neoplasm, where you have this nested architecture and you can have these sort of lymphoid foci at the periphery, and the cells have like this eosinophilic to amphiphilic like cytoplasm with this microcyst containing eosinophilic material. They can be also clear in terms of the cytoplasm. Here it's a little bit more densely eosinophilic, and you can always get to the point where it's rhabdoid. The reason I'm bringing this up in this kind of very esoteric entity up is that you have to be very careful because these can also be positive for ALK. So the point I wanted to bring up is that just because if you're in a situation where you have something that's positive for ALK, but it doesn't quite match the morphology or the clinical scenario of IMT, I don't think there's any shame in pursuing molecular studies just to make sure that it's not some sort of aberrant expression of ALK, which, to be honest, I think we're seeing more and more entities within the soft tissue world that exhibit just aberrant expression of ALK. So just be careful about overinterpreting an ALK stain if something else doesn't match. Interestingly, these odd entities can also be positive for MUC4, which can lead to a misdiagnosis of fibromyxoid sarcoma. And they can also be positive for AE1A3, which could lead to a misdiagnosis of carcinoma. So they can be very tricky. They can also express synaptophysin as well. So they're very sort of immunohistochemically tricky entities, but fortunately they're quite rare. In terms of the clinical behavior of epithelial inflammatory myofibroblastic sarcoma, and like I said before, these unfortunately are quite aggressive. 80% recurrence rate with about 25% of tumors metastasizing. Median survival is about 11 months. So unfortunately, they're quite aggressive. So this is case number 5, 60-year-old with a posterior knee mass, currently on prednisone. Here you see this spindle cell kind of tumor showing some like streaming architecture here, maybe vague store form kind of arrangement. There's some scattered sort of neutrophils, maybe like a little micro abscess right here. This is a mycobacterial histiocytic pseudotumor. I thought it'd be good to talk about this because, to be honest, I think sometimes when we think about inflammatory soft tissue tumors, the histiocytic subtype of these tumors, I think, can sometimes sort of fly under the radar, not really be considered. And it's not uncommon that when I see like a histiocytic type of pseudotumor, a lot of times the working diagnosis that I'll see like in consultation will be some sort of IMT, inflammatory myofibroblastic tumor. So, just keep in mind that, these histiocytes can form these mass-like lesions that can sometimes emulate things like inflammatory myofibroblastic tumor. Specifically with mycobacterial pseudotumors, these often arise in patients with immunosuppression, such as HIV or organ transplant. They can be in multiple anatomic locations. Patients can have lymphadenopathy, but they can also arise in skin and subcutaneous tissue, lung, as well as other locations as well. And in terms of the histology, you have these spindled cells with the irregular nuclei. I think that's one thing, in terms of the features, usually like myofibroblastic cells aren't going to have like these little undulating sort of nuclear borders that you see here. And they usually aren't going to have like the grooving that you associate with a histiocytic pseudotumor. But of course, again, Immunos can really sort of help differentiate between those two. They often have inflammatory components such as lymphocytes, and oftentimes they'll have these neutrophilic microabscesses, which can be quite helpful in suggesting a mycobacterial pseudotumor in the appropriate context. They might have multinucleated cells or associated granulomas as well. Again, showing these irregular nuclei of these sort of spindled histiocytes. Here you see a nice microabscess. Again, and you could also see these foamy histiocytes as well. And I don't have it here, but you can also see multinucleated giant cells. These will be positive for CD163. The problem with CD163 though is that, to be honest, like it can be problematic sometimes because when you're dealing with soft tissue tumors, because it's hard sometimes to discern if you're staining the actual cells of interest or you're just staining like background histiocytes. And so I've personally found, like, we've had a PU.1 for, I don't know, probably like a couple of years now. And I found that exceptionally helpful in terms of helping, because it's a nuclear stain. It's been very helpful for me in terms of like defining what cells within the tumor are actually staining. So am I actually staining the lesional cells versus just background histiocytes? So, the PU.1 stain can be very helpful, I think, in terms of determining that when you have these histiocytic proliferations. And of course, these typically will light up with a Zeal-Nielsen stain, particularly if you're dealing with an MAC type of non-tuberculosis mycobacteria. So as I mentioned, the histiocytic stains will light this up. Zeal-Nielsen can highlight the microorganisms in these tumors. In terms of inappropriate antimicrobial therapies, the critical treatment for these. But again, there's sort of a whole family of histiocytic type proliferations that can form a mass-like lesion, and that includes ALK-positive histiocytosis, cellular spindled histiocytic pseudotumor, which usually arises in the breast, an inflammatory process such as syphilis, Rosai-Dorfman, recently described in any inflammatory rhabdomyoblastic tumor, inflammatory leiomyosarcoma. Just to talk about some of these, ALK-positive histiocytosis can be systemic, particularly in younger patients, but in adults, it's usually more localized. And typically the most common area is the breast for these ALK-positive histiocytosis. Again, adults usually localized, and these are typically positive by ALK for immunohistochemistry exhibiting an ALK gene rearrangement. So this is an example of an ALK-positive histiocytosis where you see this storiform architecture. And to be honest, it has features very similar to like other histiocytic proliferations in that you have this foamy histiocytes, diffuse staining for PU.1, and you have strong ALK staining. One thing I would just caution on is that whenever you're staining these histiocytic proliferations with ALK, just make sure you have a good feel for your ALK stain, because to be honest, it's not uncommon for us to have like focal, weak, non-specific staining for ALK. So if it's not strong, I would be very hesitant to make a diagnosis without confirming on sequencing, just as an FYI. Another thing to keep in mind is syphilis, which it's making a comeback. Between 2011 and 2020, we've had an increase of 180%. And, although we think about syphilis, like, to be honest, I think is one of these things, like in med school, I kind of thought it was more of a historic entity before, I guess, its comeback. But a lot of times we think about it being like a dermatologic or, possibly like a lymph node type of process or, lung or whatnot. But in reality, like these things can form mass-like lesions, which can emulate a fibroinflammatory, like soft tissue tumor. There's substantial geographic variation in syphilis. So I suspect that like depending where a pathologist is located, they probably have varying degrees of suspicion Generally in the Midwest, it's pretty low, whereas you start getting down in more southern areas, you show a substantial increase um, in terms of the incidence rate. So this is an example of syphilis in a lymph node where, again, you see this fibroinflammatory type process where you have pericapsular fibrosis of a lymph node. You can have these areas of loose granulomatous type inflammation with background lymphoplasmacytic inflammation. You can have rare multinucleated giant cells and lymphocytic endarteritis. And again, like you can kind of go down all sorts of bizarre paths if you're not thinking about syphilis. But oh look, that's weird. Okay, and there's the treponema stain, which of course highlights the organisms in this case. So again, never a bad idea to think about syphilis, particularly, again, it's the incidence is just becoming much more common in many areas of the country now. So this is case number 6, a 61-year-old with a mass surrounding the aorta and ureters. And here you have this dense fibrosis, almost like where the collagen fibers are sort of in these different sort of directions, forming a storiform like arrangement, maybe some perivascular whorling here with some scattered areas of chronic inflammatory cells. Again, just showing this dense fibrosis. There's really not obvious nuclear atypia, showing like kind of just these stellate to spindle myofibroblastic-like cells. So this is a nice example of retroperitoneal fibrosis, which I thought it'd just be good to talk about these mass-forming fibroinflammatory lesions, which I would, kind of put, the IgG4 sort of family of processes. In addition, they're like retroperitoneal fibrosis and sclerosing mesenteritis. A subset of these can be associated with increased percentage of IgG4 type plasma cells. To be honest, like a very small minority of retroperitoneal fibrosis that I've diagnosed have had increased IgG4 plasma cells. So I definitely would not have any concern about, lack of IgG4 in making a diagnosis of retroperitoneal fibrosis. It typically arises in middle-aged to older adults. And, the radiologists are pretty good in terms of making, or at least bringing it up into a possibility, particularly when they see it encasing the abdominal aorta and the iliac arteries and the ureters, creating this bilateral ureteral obstruction. But it can involve other organs as well, such as the duodenum, pancreas, and kidneys. A minority of patients can also have associated lymphadenopathy. In terms of the features, you have this storiform fibrosis, usually this dense fibrosis, consisting of this very dense collagen, almost keloidal-like collagen. You see perivascular chronic inflammatory cells, and you can also have sheets of lymphoplasmacytic inflammation as well. In terms of the differential diagnosis, really, retroperitoneal fibrosis, I think of it as sort of a diagnosis exclusion, in that you really have to go through and eliminate, mentally eliminate a lot of different possibilities, because the morphologic features are not particularly specific. And so you really have to go through, eliminate the other possibilities, make sure it fits radiologically and clinically before, making that diagnosis. So, I have a pretty low threshold, depending on the situation, for assessing for MDM2 gene amplification if it's ambiguous. Also, you have to keep in mind that low-grade lymphomas can also have a sclerotic type of reactive response, which could emulate a retroperitoneal fibrosis. So again, going through and excluding those as possibilities is key. So this is well-differentiated liposarcoma with sclerosis, again, showing that dense fibrosis. MDM2, of course, can help exclude that, again, showing B-cell lymphoma with sclerosis. One key thing that I think to remember about retroperitoneal fibrosis, though, a lot of times a pathologist will hear a retroperitoneal fibrosis, and we sort of automatically just fill in the blank idiopathic retroperitoneal fibrosis. And I think it's very important that we have to remember that retroperitoneal fibrosis can be secondary to many types of causes. So you really need to, assess, does the patient have any medications that can be associated with retroperitoneal fibrosis? Have they had previous radiation? Could this be secondary to a metastatic carcinoma, or do they have any previous surgeries? So just be careful about jumping on idiopathic retroperitoneal fibrosis without also going through sort of that mental checklist. Here's an example here where you sort of, again, have this dense fibrosis in the abdomen in a patient. But then when you, again, showing this lymphoplasmacytic inflammation, dense fibrosis, but then when you do a cytokeratin stain, it just highlights this diffuse sort of metastatic carcinoma, which is also positive for MOT31. So this is a secondary retroperitoneal fibrosis to metastatic carcinoma. So again, you just have to use a lot of caution before jumping too quick on idiopathic retroperitoneal fibrosis, although that's, at least in my practice, typically what I end up seeing the majority of the time. As I mentioned before, also IMT can have increased IgG4 cells, so just be careful about that as well, in addition to the other entities that I mentioned in the differential diagnosis. So this is a case number 7, 70-year-old male with abdominal pain and mass in the mesentery. And so here we see these fibrous septa. And this is fat necrosis here with these foamy histiocytes. So this is a nice example of sclerosing mesenteritis, which is, again, another fibroinflammatory type process that I thought would just be nicely illustrate some of the issues with these type of tumors. The mass-forming lesion that affects adult patients typically can affect them over a broad age range. It can be either singular mass that's large, like up to 10 centimeters, or it can be like multiple masses within the mesentery, sometimes just presenting or diffuse just thickening of the mesentery. It can involve the pancreas, sometimes mimicking pancreatic cancer, and patients can have constitutional symptoms. Basically, when you think of sclerosing mesenteritis, you want to think of 3 different parts of this, where you want to see dense fibrosis, chronic inflammation, and fat necrosis. So if you're getting on an excision, if it's a good day and you're getting on an excision, that's pretty easy to do. But unfortunately, we're getting a lot of these. You're going to get a needle core biopsy, and then you're just trying to figure out how much of what component can be a little bit more difficult on a limited core biopsy. A subset, just like retroperitoneal fibrosis, can show an elevated percentage of IgG4 plasma cells, but definitely do not need that to make a diagnosis. And to be honest, it's one of these things where you want to, there's a lot of clinical and even radiologic correlation in terms of making the diagnosis, particularly of a limited core biopsy. So here, again, you have this sort of fibrous septa here, and it can sort of circumscribe these areas of fat necrosis. Again, fibrous septa with fat necrosis and these foamy histiocytes, and then these areas of fibrosis that are reminiscent of retroperitoneal fibrosis. So in terms of the differential diagnosis, it's important to keep in mind that you can have reactive changes in the mesentery that can mimic sclerosing mesenteritis. So in particular, I'm always careful about diverticulitis, because sometimes I've seen, reactive changes in the mesentery that can mimic sclerosing mesenteritis, and the patient ends up having diverticulitis. IMTs, of course, can also be in that location. So again, you want to have a suspicion for that, and also low-grade lymphoma. So this example of fibrosis from diverticulitis, where you have this dense fibrosis with lymphoplasmacytic inflammation. But usually with diverticulitis, a lot of times you're going to have either areas of acute inflammation or a foreign body like giant cells, which can help sort of clue you in and maybe getting more history from the clinician in terms of trying to assess for other possibilities. In terms of the treatment, they're typically, a lot of times they'll just watch these or like go for medical management. They will surgically excise if it starts to impede on another organ or some other structure. So the tumors often, though, will not recur or progress following surgery or initial biopsy. That's sort of kind of like a whirlwind tour of common inflammatory soft tissue tumors. Again, it's not comprehensive, but I just wanted to kind of present some of these just to give like an idea of some of the pitfalls and some of the overlaps that you can have with these entities. Again, to emphasize, I think that the clinical context can be extremely helpful in terms of knowing when and what to suspect from a soft tissue perspective. And I think having a proactive sort of approach with doing ancillary studies, particularly given the overlapping morphologies of these tumors, can also be helpful in terms of making sure preventing a misdiagnosis. And that's really all I had. This is in Vancouver. No, it's actually by Vancouver, I guess, but in British Columbia. It's the Sea to Sky Trail. It's really nice. If any of you guys are going to USCAP next year or planning on going to USCAP, you can look into hiking it. If you don't want to hike it, there's actually like a gondola ride that can take you up, and you could just like have breakfast, or like there's like a small restaurant that you can eat at, and then it can just take you back down. But it might be a little bit chilly in Vancouver, I guess in March of next year. But just FYI, in case you're looking for some things to do. But thanks again for letting me talk, and I just wanted to make sure I leave time for questions that any of you guys might have.
Do we have any questions?
So, I mentioned you mentioned in a lot of the entities that, or hold on, in a lot of the entities that you mentioned, you talked about IgG4, like in the elevation, but what does that mean to you? Like, are you saying it's elevated to the level of IgG4 related disease, but you have to differentiate it in some
I think, honestly, I just don't find, it's one of these things where I think the IgG4, I've seen elevated IgG4 in like pretty much, I just don't put a lot of stock in it. Like, it's one of these things where I think like talking about the increased IgG4, levels like of lymphocytes or plasma cells or whatnot, I think it might be helpful as long as you've excluded all these other entities. But the problem is like, I've seen elevated IgG4. You can see it in IMT. I think I believe you can see it in syphilis. So like, it's not. I guess the point I'm just trying to make is, I mean, I'm not saying there's anything wrong with ordering IgG4 in terms of trying to assess, in the appropriate context, an IgG4, associated process. But I think the problem is that people see elevated IgG4 and then they just ignore all these other entities that should be considered in the differential diagnosis before you get there. Does that make sense?
yes.
Yeah. So, I mean, I think because like, you sort of see, like you look up, okay, I need a certain amount of IgG4 cells to make the diagnosis. But then like, I think what could be lost is like, well, that's after you've excluded all these other things that can also have elevated IgG4 that are, neoplastic or infectious or things like that.
Okay. Is it possible that the two could coexist?
Sure. I mean, I guess I've never seen it. I mean, I guess it could be. I don't think I've ever seen that, but sure. I mean, it's, yeah, it's not impossible. Yeah.
I guess nothing's ever possible.
Yeah. Yeah. It's like that it's like the never say never on a multiple choice, but yeah, it certainly could be. I guess the main thing is, like I said, just it's not, I'm not trying to trash the IgG4 stain. It's just make sure and consider the appropriate differential, before you kind of go down that route. And, that's the main thing.
Okay, thank you.
Yeah.
Any additional questions?
I have a question. Hey, Kyle, Ben here, great talk. Does immune checkpoint inhibitor induced inflammatory pseudotumors ever happen? I know that, we see it in GI and other areas where patients who are on ICIs get these weird inflammatory reactions. Does that ever cause things like sclerosing mesenteritis or other tumors that you see?
Yeah, that's a good question. I have not successfully ever made like a diagnosis by checkpoint inhibitor. I mean, I have seen like in post like chemotherapy, like I think like post RCHOP, type of situations for lymphoma. But, as we probably, as it becomes more prevalent, I think we definitely, I would not doubt it. I mean, I think that from a research perspective, I think these inflammatory soft tissue tumors are interesting in that, because people talk about sarcomas being very genomically quiet. And so like why, trying to find out why do they, recruit these and what kind of tumor microenvironment are they creating, I think is of interest. But I've never at least successfully diagnosed like a checkpoint etiology. But that being said, that I might not be aware of, I could have missed it, who knows, or the medication might not be aware of that process. That's cool. Yeah, that's interesting.
Any other questions? All right. Well, thank you so much, Dr. Perry.
Thanks for having me. Yeah.